of SC crash revision and looking at the things that are important in any diabetic review. So diabetic, if you want to check how the patient has been within, you know, the kinds of, how the patient has been symptoms, if you've had any felt well, could there be any concordance or compliance with the medications, taking the medications as prescribed? If they got anything they want to discuss today, well, then you start asking more specific questions about possible screening for possible diabetic complications, kidney, arms, neuropathy, checking if they have any points sensations that limits any numbness in the hands or feet, any troubles with their vision, if noticed, passing water, how is it? The diabetic will be once complete their BMI, body weight, um, body weight, height, BMI, waist circumference, viral condition, good for you know, to be checking their blood pressure, every diabetes review, and cardio-diabetic and postural hypertension, to checking their lines, standing, sitting, standing blood pressure. You want to do a foot examination, because to check for vasculopathy, amyelopathy, so peripheral pulses, sensation, urine test, checking for glucose, protein, carbon, you want to check the blood glucose test and the HbA1c. Sometimes you just do HbA1c before they even come for their review, so they have the results available. Check their cholesterol, calculate acute risk, liver, creatinine, renal function, the thyroid, the eye examination from the scope of visual acuity, retinal, photography. These ones are usually, as a GP doing with that visual review, typically be asking if they have any eye visual symptom, but they usually will have the annual diabetic eye check, specialist eye check. They do have a thorough fundoscopy and a retinal photograph. It's saved to recorded. So what's called relevant to COVID actually. I'm sure it's relevant in this case. Mm, exactly what I said in data gathering. Mm, mm, mm. Okay, so choosing the first line treatment in diabetes. So obviously, how to choose first line medications. Rescue therapy for symptomatic hyperglycemia, consider insulin or sulfonylurea and review when blood glucose control has been achieved for symptomatic hyperglycemia. For information on using SGLT, assess HbA1c, cardiovascular risk, and kidney function. Patient is not at high cardiovascular risk, which means Q risk less than 10%. Usually, you would typically offer metformin. The patient is having GI disturbance, you use metformin modified release, which is modified release, obviously is slower absorption. If there is chronic heart failure or established atherosclerotic cardiovascular disease, risk offer metformin in GI risk for the metformin MR modified release. And as soon as metformin tolerability is confirmed, offer SGLT2 inhibitor, like the dapagliflozin, with proven cardiovascular benefits. So if there is significant cardiovascular risk, as soon as metformin has been optimized and tolerated, want to be introduced on the LGLT, SGLT, commonly dapagliflozin. If there's a high cardiovascular risk, which means Q risk, of 10% or more or higher elevated lifetime risk. You have to, most times you start with metformin, if the GI disturbance, use the MR, and as soon as metformin tolerability is confirmed, consider SGLT2 inhibitors like dapagliflozin with proven cardiovascular benefits. If metformin is contraindicated, so if the patient has a low cardiovascular risk and cannot take metformin, the next one wants to be contraindicated, wants to be considering medications from here. So you can consider a DPP4 inhibitor like the allogliptins, saxagliptins, so medications like or the pioglitazone, conjugate pioglitazone, sulfonylureas. So consider glitazide. An SGLT inhibitor for some people, canagliflozin, dapagliflozin, empagliflozin, etugliflozin. In those with heart failure or significant established cardiovascular risk, if metformin is not if metformin is contraindicated, then if, for instance, if a patient is having non-alcoholic liver disease with metformin, then obviously we need to be offering SGLT2 inhibitor alone. Okay. And then we can go there. Person's HbA1c not controlled below individually agreed threshold, or the person develops cardiovascular disease, see treatment options if further investigations are needed. Typically, it's also good to establish the target HbA1c for someone who is physically well, fit, not frail. You typically want it to be on the HbA1c to go to be within either normal or within the pre-diabetic range, so less than 48. For someone who is not very, who is not fully fit, you want it to be less than 54, which is 53 and below. HbA1c. It's good to have a documented, established, agreed HbA1c target. Yeah, for someone with significant cardiovascular disease with metformin is not contraindicated, then SGLT2 inhibitor alone, you put a package with. You start metformin alone to assess tolerability before adding an SGLT2 inhibitor, of course, just so that if patient is having side effects, you're sure if it's a side effect of metformin or a side effect of the SGLT2 inhibitor, you need to show that. Established atherosclerotic cardiovascular disease includes coronary artery disease, acute coronary syndrome, previous MI, stable angina, prior coronary or other revascularization, cerebrovascular disease, ischemic stroke, transient ischemic attack, or peripheral artery disease. NICE technology appraisals recommend SGLT2 inhibitors as monotherapy options in people who cannot have metformin, in those for whom diet and exercise alone do not provide adequate glycemic control. The SGLT2 inhibitors are recommended only if a dipeptidyl peptidase 4 inhibitor would otherwise be prescribed in a sulfonylurea or pioglitazone is not appropriate. In February 2022, using etugliflozin to reduce cardiovascular risk when blood glucose is well controlled is powerfully then. Of recent, I've seen it appears as this semaglutide, semaglutide that is used in management of diabetes and weight loss management as well, appears to be. But I think a lot of patients are beginning to opt for that semaglutide, especially patients who are maybe overweight or obese, just to get that extra benefit of weight loss. Metformin, obviously, it's also important because it's one of the side effects of metformin, one of the desirable side effects a lot of times weight loss. So for people who are obese, metformin is also very important. That's why if you remember, metformin can be used in management of, patients with polycystic ovarian syndrome who may be struggling with their weight. So metformin. Those patients with PCOS can also have hyperglycemia, type 2 diabetes. So metformin is also important in that management. Now, so we've established the initial treatment is usually metformin. If it's not tolerated, the SGLT2 inhibitor. But then the patient still having uncontrolled blood sugars. For the next thing, you have to choose medicines for further treatment. For symptomatic hypoglycemia, consider insulin or a sulfonylurea review when blood glucose control has been achieved. Treatment options if further investigations are needed at any point. HbA1c not controlled below individually every threshold. Switching or adding treatment, you switch or you add on something else. Consider your DPP-4 inhibitors or pioglitazone or sulfonylurea. SGLT2 inhibitors may also be an option in dual therapy or in triple therapy. Now, at any point, cardiovascular risk or status changes. If the person has or develops chronic heart failure or established atherosclerotic cardiovascular disease, switching or adding treatment, offer SGLT2 inhibitor if not already prescribed. If the person has or develops a high risk of cardiovascular disease, Q risk 3 of 10% or more, or elevated, like risk switching to add an consider an SGLT2 inhibitor if not already started. Now, insulin therapy. When dual therapy has not continued to control HbA1c to below the person's individually healthy threshold, also consider insulin-based therapy with or without other medications. If patients are on metformin and maybe dapagliflozin, or the person maybe couldn't tolerate metformin, the person was started on dapagliflozin, it's maybe on allogliptin as well, or even semaglutide injection, something. So the person's on dual therapy and not well controlled. You start thinking, could there be some insulin deficiency as well? So you could start discussing the option of introducing insulin into their regimen, treatment regimen. So GLP-1 mimetic treatments, if triple therapy with metformin and 2 other oral medications is not effective, not tolerated, contraindicated, consider triple therapy by switching one of the medications for a GLP-1 mimetic. For adults with type 2 diabetes who have a body mass index of 35 or more, so morbidly obese, adjust accordingly for people from Black, Asian, and other minor ethnic groups and specific psychological or other medical problems. If people have BMI lower than 35 and home insulin therapy would have significant occupational implications, or weight loss would benefits other significant obesity-related conditions. So the GLP-1 mimetic treatments. The GLP-1 mimetic treatments. Let me have a quick look at this GLP-1 mimetics. So things like enzamatide, yeah, semaglutide. So that's where our semaglutide comes in. Because I just double check. That's where our semaglutide comes in. That's why you can see. That's why it looks as if semaglutide, seems to be not very common. Just a few patients have actually seen semaglutide injection. But now a lot of people are asking for it because they want it for weight management. So it's a GLP-1 mimetic, at least an injection as well. It can be a tablet anyway. Look at some. So set glycemic target HbA something less than 53 millimole per mole or individualized as a grade. The person is very fit and young, fit and well. Usually we want our target to be less than 48 actually, the lower target. Then if they're having hypoglycemic episodes at that on that level. In terms of metformin, in terms of weight management, metformin can cause weight reduction, but you can see sulfonylureas and cause weight gain. So if patient has CKD stage 3A, maximum daily dose of metformin is 2 grams. SGLT2 inhibitors can also cause weight loss, which is good. So good to know that the dapagliflozin can cause weight loss. The risk of hypoglycemia is low. Hypoglycemia is low with dapagliflozin. The risk of hypoglycemia is low with metformin. See that? Obviously, the risk of hypoglycemia is high with sulfonylureas. In terms of weight management, as a neutral, so the DPP-4 inhibitors neutral. The GLP-1, GLP-1 is semaglutide, is obviously can cause weight loss. The main adverse effect of semaglutide, gastrointestinal side effects. Main side effects of sulfonylureas and hypoglycemia. The main side effects for metformin is gastrointestinal, nausea, vomiting, loose stools. We know that metformin can also cause non-alcoholic fatty liver, so NASH is either the side effect or complication. Like what I was saying, so treatment targets. Well, yeah, they say the person is healthy, reasonable life expectancy. Okay, so it's 58. Less than 58. Here we saw less than 53. I think I saw intermediate health less than 64. Or health less than 60. Oh, okay. It goes that high. It gets less than 48 for people that are healthy. Where did I see that? Says glycemic targets less than 53. So it's worth knowing anyway. That's maybe for younger people, less than 48. But here they say for those who are over 65 years. Okay, for those who are over 65 years, less than 58 for healthy, intermediate, less than 64. Okay, that's what we need. Worth knowing about the GI of foods, glycemic index of food. So glycemic index means after a food has been eaten, at what rates, how rapidly is the sugar content released into the blood. So of course you want to encourage patients to eat eating foods with low glycemic index. So if you look here, you see things like wholemeal, so wholemeal, frozen, so peas, I think soya bean, soy, nuts. So apple has a low glycemic index, which is why a lot of people notice because like turning to apples more. Banana has a high glycemic index, which means after eating one banana, so if you're in a situation where you need rapid, sugar content in the blood with little volume of food, banana is actually a good to. If your banana has a high glycemic index, obviously the basmati rice, so rice has a very high glycemic index. Potato has French fries, spaghetti, sweet corn, fairly high, peas, apples low, um, wholemeal, see broccoli has a very low glycemic index. It doesn't mean it doesn't have glucose, but what it means is that to release the glucose into your bloodstream very slowly, which is actually what you want to do. More likely to have a stable glycemic control. Glycemic index of foods or fruits. So let's look at some fruits. So strawberries are actually healthy and they low glycemic index, they release sugar slowly. Banana has a high dosage, you need that, especially when you're exercising at the gym and you think you're beginning to get tired and you need that energy boost. So you don't really want a lot of volume. Banana is a good too. It's usually good to send patients information link on foods and their glycemic index and encourage them to eat more foods with lower glycemic index. I think this is, you can see apple there. Very low glycemic index. Strawberry is very good, low glycemic index. So if you really want to start improving on your healthy and your dietary lifestyle, you want to be eating healthier, you want to improve your fruits intake. If you're thinking of strawberry or apples, actually, you should also be thinking of things like broccoli. Start eating broccolis. Broccoli is good to when you want bulk, so you're feeling hungry, you want to fill up your stomach, or you want something that has a low glycemic index. Broccolis are good. Cabbage, low glycemic index. Potato has a high glycemic index. Raisins, look at how raisins. No wonder raisins also, raisins have a very high glycemic index. So not really the best. Let's look at rosacea. So previously called acne rosacea because usually typically appears on the face spots as well. So mild papulopustular rosacea. So you typically moisturize gel or cream, apply twice daily for 3 to 4 months. So that's usually for like 3 to 4 months. Azelaic acid cream is also used. Azelaic acid is also used in management of acne. If you use azelaic acid cream, apply twice daily. Sensitive skin once daily for the first week. Moderate or severe papulopustular rosacea, moisturize gel or cream, apply twice daily for 3 to 4 months. You can also use ivermectin cream, percent ivermectin cream, to apply once daily for 4 months. Discontinue after 3 months if no improvement is seen. Then oral doxycycline, so capsules, modified release 40 milligram doxycycline. Doxycycline capsules, you don't have to use this modified release 40 milligram. So 40 milligram daily in the morning for 16 weeks. Consider discontinuing treatment if no response after 6 weeks. The limecycline, you can see limecycline, so you can see medication that could be used in the treatment of acne as well. And doxycycline and limecycline on licensing, 408 milligram once daily. If you have 2 months and continue for a total of 3 months, if responding well, you get 3 monthly costs when rosacea fails. You'll be taking with food, but avoid antacids, iron, and zinc at the same time. Actually, what main, well, typically it was very mechanized with gel, so as a like it's a cream could be used. And there's a lot of the doxycycline and limecycline, or even ivermectin cream. Okay. It's good to know. And good to know. We should look at reflux in babies as well. So this reflux managed in babies. So previously we've looked at management of cow milk protein allergy. We looked at that. So clinically, when a patient, one parent comes with their child, typically an infant, and they tell you that the child is very unsettled after feeding, you start thinking, could it be reflux? Could it be cow milk protein allergy? So these are also things that I need to work out which is likely present or could both be present. Most times it's more likely reflux. Reflux is much more common in babies. And that's because of the short esophagus. It's more common, much more common as well in babies that are formula fed or mixed fed. because sometimes it could be difficult to gauge how much the child actually needs. In a child who is breastfeeding, the child can always, stop breastfeeding when they're satisfied. But in formula fed babies, because it's the parent that is giving the child food, there's a tendency the parent are giving the child too much feeds or too much food and works in reflux. You look at the small capacity of the stomach, gastric capacity, the small length of the esophagus. I think the angulature of the gastroesophageal junction as well is still not fully developed. In sphincteric function is not fully developed at that age, so they are more prone to reflux. So formula-fed infants with frequent regurgitation associated with max distress. And it's that max distress that might begin to make you think, oh, could there be some allergy as well? Step 1, review feeding history. Normal volume should be 150 ml per kilogram body weight per day. So you need to calculate, especially in formula fed or mixed fed babies, how much are they feeding this child in a day. Then reduce the feed volumes only if excessive for the infant's weight. Then offer another thing that you can do is even if the volume of the feed is within this calculated amount, you might need to tell them to reduce the volume per meal, what's spread. So which means when I feed the child, you are feeding the child for three times a day previously. You might not be feeding the child 5 times a day, smaller volumes per feed. Offer a trial. So if you reduce volume and the child is still having symptoms, obviously offer a trial of smaller, more frequent feeds, maintaining to 2 daily amount of milk in accordance with the baby's feeding cues. Then offer a trial of thickened formula, for example, containing rice starch, cornstarch, locusts, bean gum, or carob, bean gum. Now, carob is the recommended first line option, so carob, take as a thickener. An effect of a thickened formula should be seen in a few days. If successful, continue using the thickener. Try stopping at intervals to see if the infant has recovered. Some babies may require a thickened formula for the 6 months when solids are introduced. Thickened feeds should not be prescribed for more than 6 months duration. I'm not sure why. What's the reason for not prescribing thickened feeds for more than 6 months duration if unsuccessful? If you've tried the thickener, particularly the Carabel, if unsuccessful, stop the thickened formula and offer alginate trial. But typically, we use Gaviscon infants as an alginate. So, if you tried thickener as not helping, then offer the alginate trial therapy for 1 to 2 weeks. Because, do not offer acid suppressing medications to treat Offered cogitation in infants and children occurring as an isolated symptom. So you shouldn't be thinking, don't be in haste to start thinking of omeprazole and things like that. Gaviscon infants, thickeners, try thickeners, or modify the feeding habits. First of all, try thickeners, and you will try alginates. This is a formula fed babies. Okay? Now, breastfed babies are less likely to have reflux issues because the baby decides when they feed. When they are full, they stop suckling. So far less likely to have issues with vegetation. But if a breastfed infant is having frequent vegetation, first thing is skilled breastfeeding assessment. You want to make sure the mom is not even force feeding the baby, because some moms could force breastfeed the baby as well. The baby is satisfied now, and she sticks the nipple into the baby's mouth and starts squeezing the breast and things like that. So that's obviously abuse, child abuse. So step 2, with frequent regurgitation associated with max distress, try alginates. So at that stage, you can't be talking about reducing the amount of feeds, but you can't calculate how much breast milk the baby is having, right? Babies exclusively breastfeeding. If I have to carry on breastfeeding, we have to be thinking, you have to rule out symptoms of possible cow milk protein allergy that might make you want to think, ask her to try cutting off cow milk, from her own diet, for instance. But if you're not suspecting the presence of a cow milk protein allergy, then You just try alginate for 1 to 2 weeks and see if that helps. They stop in at regular intervals to see if the infant is recovered. Okay. So more on reflux in babies. Pharmacological treatment of gastroesophageal reflux disease. In a small proportion of infants, gastroesophageal reflux may be associated with signs of distress or may lead to certain recognized complications that need clinical management. This is known as gastroesophageal reflux disease when it's symptomatic, causing distress, causing some complications. Do not offer acid suppressing medications such as H2 receptor antagonists or proton pump inhibitors to treat overt regurgitation in infants and children occurring as an isolated symptom. Isolated is emphasized. For those unable to tell you about their symptoms, consider a 4-week trial of PPI or H2 receptor antagonists. If any of the following, so unexplained feeling difficulties, yes, unexplained feeling difficulties, distressed behavior, and faltering growth, with the easy transfer omeprazole, some syrup omeprazole, assess after 4 weeks, and consider referral to a specialist for possible endoscopy. Imagine doing endoscopy in an infant. It's going to be a traumatic procedure. Do not resolve. If symptoms do not resolve, so after 4 weeks of trying your PPI or H6 September and symptoms not resolved, want to refer to a pediatrician. Um, so pediatric gastroenterologist, because be the one doing the endoscopy. If symptoms recur after stopping treatment, if children and young people, in children and young people, consider a 4-week trial of PPI or H2 receptor antagonists, ranitidine, with persistent heartburn, having persistent heartburn, retrosternal or pediatric pain. Yes, offer PPI or H2 receptor antagonist treatments to infants, children, and young people with endoscopic profile reflux esophagitis. So that's endoscopic profile confirmed or reflux esophagitis. Then we're giving the PPI or H2 receptor antagonist. Those children. Okay, so we continue from the center scoring next.